Hey, and welcome to your EMT lectures. Today we're going to go over Chapter 9, which is our airway management. So we're going to talk about the physiology, the pathophysiology, airway adjuncts, suctioning, keeping that airway open, and any kind of special considerations. Okay? So, physiology. So our upper airway, that's the mouth and the nose. That's where our air is breathed in and it's warmed and humidified. And then we go down to our pharynx, our oral pharynx, our nasal pharynx, the laryngeo-pharynx, and then it ends at the glottic opening. Okay, so we've got all this air that comes up and goes in, gets humidified and warmed, and then it goes into the glottic opening right about here. And then down in the trachea, which is where that lower airway begins. So it begins at below the larynx, and it's composed of the trachea, the bronchial passages, and the alveoli. So here's our larynx right here. In terms of the epiglottis would sit right up here in that little area. And then, of course, it goes down into the trachea, and then it'll go down into the different branches and finishes out at the alveoli. So our alveoli are those tiny sacs. That's where all of the blood vessels and the arteries and the veins, they make that little net that goes around the sacs of those alveoli. And what happens is when we breathe air in, all of that oxygen gets exchanged to the blood cells, and the blood exchanges it with carbon dioxide. Okay? So these are our little sacs, our alveoli. All right, so pathophysiology. So we've got a variety of obstructions can interfere with the flow of oxygen. Okay, so we've got foreign bodies, food, small toys, beads, rocks. My kids are known for putting rocks and beads in their nose and their mouths and eating them. So always check for a foreign body. Liquids, blood, vomit. I mean, you can get choked on soda, coffee, whatever. Okay. And then it may also result from poor muscle tone from being altered. Okay. So you have to be particular, have a heightened awareness with your drunks. They can't necessarily protect their own airway because they may have that poor muscle tone, and it may just collapse on them. So these obstructions can be acute or chronic. Acute, we're talking like right now in the moment. So like acute obstructions can be those airway problems, keeping that open airway, the foreign body obstructions, blood, vomit, anything like that. And then we have to evaluate the airway and monitor the patency of that airway over time. We can't just like say at the very beginning of the call, assess the airway and say, hey, it's good. We have to continually monitor that airway. Make sure that, something hasn't changed that now has caused the patient to to not have that open airway. So we talked about this. Okay, so airway obstructions, chronic airway obstructions, could be edema from burns, trauma or infection, and decreasing mental status. So that edema, it can happen. It happens with burns, where you either get like an inhalation burn, and that inhaled hot superheated air gets into the lungs, gets into the trachea, and eventually just causes swelling into the tissue surrounding the trachea. It's not the trachea itself getting swelling, it's that tissue around the trachea swelling. Okay. Bronchoconstriction. This is a disorder of the lower airway. The smooth muscle constricts the internal diameter of the airway. So when we have this bronchoconstriction, if you remember back in slide, this one, okay? So what's happening is these bronchioles and bronchi are getting constricted, and they're getting smaller. So that's where we get the bronchial constriction. Okay. So our patient assessment. So it's this, we want to make sure that we have an open airway, and when we check for that open airway, it's probably the very first thing that we do. I know it is for me because I can look at my patient and say, you know, are they looking at me? Are they talking? You know, are they alert? If they're alert, they probably have an open airway. Okay. If they're talking, they probably have an open airway. In fact, they do have that open airway. Okay. So in the back of your head, while you're assessing your patient and looking at your patient, you want to look and ask these two questions. Is the airway open, and will it stay open? Okay. Is there some reason that the patient's airway may close at any point during our treatment? So we're going to be looking for, you know, signs of airway compromise. Are they having a decrease in mental status? Are they, you know, did they have some type of trauma to the area? Are they having an allergic reaction that's going to cause swelling and edema around the trachea and close it off? So those are the two questions that you want to ask in the back of your mind and just kind of go through. Like I said, this can be assessed by as simple as a question as the patient saying hello. So, you know, when you first walk into that patient's room or, you know, house or whatever, and you've got that patient on the floor or however they're sitting, and they're looking at you, they acknowledge you, they start to talk to you when you ask them a question, that means you got an open airway. Okay. The sniffing position is seen when swelling obstructs airflow through the upper airway. So what we're doing is in that sniffing position, they're like sniffing, like dogs put up their nose and they sniff around. Same thing, okay? So they're going to be lifting up their heads, they're going to be lifting up their chins up to the sky to kind of try and move more air into the airway. Okay? So findings of indicating breathing problems. We're going to talk about inadequate and adequate breathing in the next lesson. But we're just talking about the open airway right now. Okay. So findings indicated breathing problems. Okay. So we've got inability to speak, unusual raspy quality to the voice, stridor, snoring, gurgling. Stridor is that sound where it's kind of a high-pitched whistly sound. Snoring, we've all heard snoring. Probably have somebody that we were close to that has snoring. My wife. Gurgling. Gurgling is just that sound when you've got just some mucus or some type of fluid inside the airway. So just be aware of all these things. So then we want to ask that question of, will the airway stay open? It's not just that one moment in time at the very beginning of the assessment. We need to reassess that airway continually. Even on the normalest of patients, we want to make sure that we reassess that airway. Because if we don't, then we're going to be trying to play catch up later on down the road when we don't have an airway. And now we're to the point where, you know, you as an EMT, you don't really have much option. You're going to have to call ALS, and that ALS provider is going to have to potentially have to crike a patient, which is just taking a knife and cutting down the middle of the neck and putting a tube down into their neck directly because they don't have that open airway. So we talked about a little bit about this, okay? So signs of an inadequate airway. There's no signs of breathing or air movement. There's evidence of foreign bodies in the airway. There's no air felt or heard coming from the airway. And there's an inability or difficulty to speak. They have that unusual hoarse or raspy voice. That is typically something that we see in inhalation burns. And then absent, minimal, or uneven chest movement. Okay. More signs: abdominal breathing, diminished or absent breath sounds, abnormal noises such as wheezing, crowing, stridor, snoring, gurgling, gasping during breathing. And then in children and infants, you're going to see nasal flaring where their nares just kind of flare out and flatten. And then also in children, you're going to have some retractions right above the clavicles, right up here. You're also going to see some seesaw breathing in infants, where we've talked about it, where the chest rises, the stomach falls, or the stomach rises and the chest falls. That's what we call seesaw breathing. Okay. I'm not going to show you these videos in this particular lesson, but they will be attached to the in the online classroom. So opening the airway, when our primary assessment indicates that we need an airway, it's a life-threatening condition. Again, if you don't have airway, breathing, or circulation, okay, airway and breathing go hand in hand. If you don't have one of those three things, then you can't do anything else. You have to fix those three things before you can fix anything else. So it's a life-threatening condition. You want to take prompt action to open and maintain that airway. Okay? It's got to be done right then and there. It cannot wait. Okay? So if the airway is not open, we're going to use a position to open it. Okay? Indications of head, neck, spinal injury. If the mechanism of injury is known to cause such injuries, if they have any kind of injury at or above the level of the shoulders, or if bystanders give any kind of information that leads you to suspect it, then you should probably take into consideration the type of airway maneuver that you're going to use. And we'll go into those as a jaw thrust for a spinal injury or a head tilt chin lift for a normal patient. Okay, so this is that head tilt chin lift maneuver, and all it is it opens those airways. Okay, here we see the picture. We're going to place the hand closest to the lower body on the chin, and then we're going to place the hand that's closer to the top of the head on the forehead, and we're just going to push down with our forehead hand and lift up with the chin hand. And what that does is it lifts that airway up and the tongue out of the way, and it opens that airway, hopefully. Okay. If it doesn't work, then what you're going to do is you're going to let the head go back into the normal position that it was in, and then you're going to retry it. Okay. This is the jaw thrust. You're going to be at the head of the patient. You're going to place your thumbs right here on the zygomatic bone, okay? And what you're going to do is you're just going to push up with these two fingers and push that jaw up. And what that does is it brings the tongue up out of the way and allows the airway to be opened. Okay, all of these step-by-step things and pictures on how to do it are in the skills portion of the online classroom. There's PowerPoints for each skill, so I would strongly encourage you to go through those before coming to skills sessions and doing all of that. So airway management, after the airway has been opened, and the position must be maintained to keep the airway open, okay? It's not just, let's open it and then be done, and then we can let go because, oh, now we have an open airway. No, you have to maintain that position. So if you've got to hold that airway open, then you've got to, okay? And then the airway must be cleared of any kind of secretions and other obstructions if necessary, okay? Airway adjuncts, okay, you've heard me talk about some of these. So airway position and maneuvers are short-term solutions, okay? Airway adjuncts provide a longer-term air channel, okay? So when we start to open that airway, if we don't get that airway open on the first try with a head tilt or jaw thrust, then we're going to go ahead and let the head go back into that sniffing position or the neutral position, and then reopen it, try and reopen it. And then if it doesn't work, or it does work now, and we've got the airway open, they're breathing again, hey, great. But you can't just sit there and hold it, okay? We've got to provide some type of airway adjunct, okay? So we're going to provide an OPA or an NPA. So an OPA is an oropharyngeal airway, and an NPA is a nasopharyngeal airway. So an OPA goes into the mouth because it's oral, and then a naso goes into the nose because of the nasal passages, okay? So rules for using the airway adjuncts. Use the OPA only on patients not exhibiting a gag reflex. A little tip, it doesn't work for everybody, but if they're unconscious and if you take your finger and rub right on their eyelash, then their eyes move, the patient may have a gag reflex, okay? So then we're going to open the patient's airway manually before using that adjunct. And then when inserting the airway, take care not to push the patient's tongue into the pharynx. So we're going to make sure that we lift that tongue up out of the way. Okay. Have suction ready. Sometimes when we're sticking something into the throat, they're going to gag. And what happens when you gag? You throw up. Okay. Excuse me. So, if they gag, we're going to take out the airway, we're going to suction, and we're going to try and do something else, okay? If it does go in without any problems, then we're going to maintain that head position after the adjunct is inserted and monitor that airway. Just continue to be ready for suction. These patients may or may not regain consciousness. If they do, or they develop a gag reflex, then we're going to remove that airway immediately. If they become conscious again, we're going to remove that airway because now they should have a good patent airway on their own. If not, and they're semi-conscious, you're going to just leave that. You're going to either switch to from an oral airway to a nasal airway just to keep that airway open. Nasos can be used on semi-conscious patients, whereas oral pharyngeals can only be used on unconscious patients. I actually had a patient one time who I was the only one on scene, and I was trying to treat her. She was in and out of consciousness. She would become unconscious, and I'd stick a nasopharyngeal airway in her, an NPA. And then she would wake up. She'd pull it out, laugh at me. She'd go unconscious again. I'd stick the nasopharyngeal airway in. She'd wake up again, pull it out, laugh at me, and go unconscious. And the worst part about it was she was, yeah, I'm not going to go there. All right, so oropharyngeal airways. So this is a device used to move the tongue forward as it curves back to the pharynx. There's sizes, infant to adults. So pink, okay, infant to adult. When you see, the pink, that's typically the pediatric side of things. And you can see that they get bigger. And that it has that curve to allow for it to go to the back of the throat to keep the tongue up and out of the way. Okay, so we're gonna size the oropharyngeal airway. So we're gonna take the flange here, place it at the corner of the mouth, and then we're gonna take it and place it down to the jaw, the back of the jaw. Okay. Sorry. We're going to measure from the corner of the mouth to the tip of the earlobe. Okay? In that picture, they're measuring from the center of the mouth to the back of the jaw. Okay? So inserting, again, all of these pictures, all of these skills are in the skills section of the online classroom. So I'm not going to go through a whole lot of them. So we're going to use you can use the cross finger technique. I don't suggest doing it because sometimes the patient's mouth can be clamped. But you can just lift up their mouth and open and insert it. Okay. So there's a couple different ways. This says to gently rotate at 180 degrees, where you stick the curved towards the back of the mouth, and then once you get it in there a little bit further, you're gonna rotate it all 180 degrees. I don't like this method just because it causes a lot of damage inside the mouth. So what we're gonna do is we're going to insert it either at the side of the mouth and then rotate it 90 degrees, or you can just stick it in at that normal angle where the curve is towards the back of the mouth. That tip is at the front of the mouth, the bottom, and you can just insert it as it would normally naturally insert, how you would think. Okay. So a nasopharyngeal airway, or an NPA, is a soft, flexible tube. It's inserted through the nostril and into the hypopharynx, and it moves the tongue and soft tissue forward to provide a channel of air. Can be used with patients with an intact gag reflex or clenched jaw. Contraindicated if clear cerebrospinal fluid is coming from the nose or ears. Typically what that means is that there's a basilar skull fracture. There's been studies out there that say, hey, you're really not going to touch the brain with an NPA, so it's not something that you want to be careful with doing it on a head injury. If you can avoid using an NPA, then avoid it. But if that's the only way that you can get an airway, that's the only way that you can get an airway. Okay. They come in various sizes. The typical adult sizes are 34, 32, 30, and 28 French. The bigger you go, the bigger the numbers, the bigger the size of the diameter of it. Okay. So the way we're going to measure to place the NPA is we're going to place it from the tip of the nose, the nostril, to the earlobe, or to the angle of the jaw. So they've got it either one right there. Okay. We're going to lube it up really good. We're going to use a water-based lubricant. Typically, they come with some type of like jelly or lube. So you're just going to lube it up. And then we're going to push the tip of the nose upward, keeping the head in neutral position. Insert into the nostril. Advance until the flange rests firmly against the nostril. Okay. So gently push the tip of the nose upward. Insert the airway with the bevel side toward the base of the nostril or toward the septum. Okay. And then insert until the flange rests at the nostrils. Okay, suctioning. We're going to remove any kind of obvious liquids that are coming from the mouth, because if we don't, then all of those liquids could go into the airway and into the lungs, and the patient could aspirate. We're going to use some type of vacuum device, and we'll get into those. Okay, so there's mounted suction systems. These are typically installed into the ambulance, and the ambulance has the suction canister mounted into the ambulance. It's all pre-installed on there. Excuse me. We're going to furnish air intake of at least 30 liters per minute. It generates a vacuum of no less than 300 milligrams of mercury when collecting the tube clamped. Okay. So portable suction units, same requirements as the mounted ones. There's oxygen powered or air powered, or there's powered by batteries and electricity. Or there's manual. I have yet to actually see an oxygen or an air powered one on a truck. Typically, you're going to either have a manual one or one that's powered by like batteries, rechargeable systems. So there's different tubing tips and catheters. Okay, so we've got the tubing, which goes from the canister to the actual tip. And then you've got suction tips. There's soft tips. There's hard tips. There's a bunch of different tips. Okay, and then there you've got the collection container. And then a container of sterile water. So this is a mounted unit. It's got the canister, the tubing right here. There's also tubing that goes from the actual suction unit to the canister that creates that pressure inside the canister, which then creates the suction inside the tube. And then you can see back here that there is a hard suction tip in the back there. Typically when you're going to see these mounted and set up ready to go and ready to deploy, you're going to see the hard suction catheter on there first, because that's typically what you're going to use at the very beginning, because you're just suctioning right out of the mouth. So the rigid or those hard pharyngeal suction tips, we also call it a yonker. It's a large bore and it's more flexible than catheters. Sorry, it's a bigger bore than flexible catheters. So this is that pharyngeal. It's curved, okay, to allow for insertion deep into the mouth. But all we're going to do is just to the base of the tongue. If you go any further down, you'll probably make them gag, and you just defeated the whole purpose of suctioning. Okay. Suction only as far as you can see. Do not lose sight of the distal end, and careful insertion helps prevent that gag reflex or vagal stimulation. Okay. Flexible suction catheters are designed to be used when rigid tip cannot be used. It can be passed through a tube, such as a nasopharyngeal airway or an endotracheal tube. Can be used for suctioning the nasopharynx as well. They come in various sizes, identified by a number and French. So the larger the number, the larger the catheter. Okay. These are typically not large enough to suction vomitous or thick secretions. They can kink. And then in the event of copious thick secretions, consider removing the tip or catheter and using large bore rigid suction tubing. So it's measured in a similar way as the OPA. The length of the catheter should be inserted into the patient's mouth, and it equals the distance between the corner of the patient's mouth and the earlobe. Okay, so the corner of the mouth to the earlobe, and that's just as far as we're going to insert that suction. Okay. Use appropriate infection control practices while suctioning, and that includes eyewear, goggles, mask, disposable gloves. Technically, because you're dealing with the airway, you should probably put on a gown. Just various things. Okay. Suction no longer than 10 seconds. This is a guideline. In order to get the airway clear, we may have to suction for 15 seconds. Is that going to hurt your patient? No. You can suction for longer than 10 seconds. Just don't make it an obscene amount of time. Okay? Because they need that airway. They need the breathing. They need the oxygen. So just make sure that you're not suctioning for 30, 40 seconds. Okay? I would suggest probably no more than 15, because we need to suction that airway and make sure that we've got all that stuff out. Okay. Place the tip or catheter where you want to begin suctioning and suction on the way out. So we're not going to suction on the way down. We're going to suction on the way out. So we're going to insert the tip of the catheter, the yonker if it's a hard suction, or the soft tip suction, and then suction on the way out. Okay. So this is a video showing you how to suction through an OPA. If you see an OPA, and we'll go through them when we do skills, but if you look at this OPA here, it actually has an opening down the middle of it. Some of the ones that you may see, they'll have flanges on each side where you can insert the suction tubing right down next to the OPA and use it as a guide into the mouth. Okay, so keeping an airway open, definitive care. Okay, so keeping that airway is probably going to exceed your capabilities. Okay, we do have options. We have the LMA, the iGel, the King, the Combi Tube. If you're older like me, you were around when they had the esophageal obturators. I mean, there's so many different airways out there, and those are all called blind airway insertion devices or supraglottic airway insertion device. So all of those things can be used to open an airway. And I am perfectly fine as a paramedic to not intubate a patient if I don't have to. If I come on scene and there's a BLS crew there and they have placed an LMA, a King, an iGel, or whatever, and it's working for us, I'm not going to screw with that. Why would I screw with a good thing? Okay. Sometimes, though, however, medications or surgical procedures may be necessary to keep that airway open, as in the case of like swelling. Okay, so if the patient has severe swelling, you're not going to be able to get one of those devices down there. You're not going to be able to get a King or an iGel down. You're going to have some type of surgical procedure to be able to do that. Okay, and again, rapidly evaluate and treat airway problems. Quickly recognize when more definitive care is necessary, and you may need advanced life support, but you may also be closer to the hospital than an advanced life support. If you are, then get to the hospital, okay? Do not wait for ALS to get on scene. So if you're not able to manage an airway at the basic level, what advanced resources might be available to you, okay? So we talked about those, you know, calling for an ALS crew, getting out to the hospital as quickly as possible. If you've got the use of the iGel or the Kings or, you know, some type of supraglottic airway, then hey, great, stick one of those down, okay? All right, so special considerations. Facial injuries. These frequently result in severe swelling or bleeding that may block or partially block the airway. Bleeding may require frequent suctioning or more definitive airway. If you Google trauma to the face, probably the #1 picture you're going to see is a patient that has blown out their face, and their chin is all down, and all you can see is like inside the muscles and everything like that. Okay. Obstructions. So many suction units are not adequate at removing solid objects. Objects may have to be removed with manual techniques such as abdominal thrusts or chest thrusts and finger sweeps. Dental appliances, so dentures we're going to leave in place during airway procedures if possible. Typically you're going to remove those. Just take out that dental airway, that denture, so that way it's not causing a problem and it's already out of the way. Okay, so a pediatric note in airways, they are not small adults. Okay, some people will tell you that they are, some people won't. Some people will tell you that they're not. In some ways they are, in some ways they're not. Okay, we can't treat them like small adults, but they have the same anatomy as the adult does, and they can have those same issues. Okay, they have a smaller mouth and nose. They have a larger tongue. They're more narrow and flexible in the trachea. Okay, so anatomical considerations. Okay, so our nose and mouth are smaller than an adult. The tongue takes up more space because of the smaller mouth. Their cricoid cartilage, which is this cartilage right here along the trachea, it's less rigid and less developed. Okay, and those airways in the pediatric patient can be more easily obstructed. Okay, so open our airways gently with pediatrics. Don't over or hyperextend their necks. Consider adjuncts when other measures fail, and use a rigid tip adjunct, but don't touch the back of the airway if at all possible. Okay, chapter review. The airway is the passage by which air enters the body during respiration and breathing. Okay. A patient cannot survive without an open airway. Airway adjuncts, we've got the OPA, the MPA. Those can all help keep the airway open. Okay. It may be necessary to use suction and suction the airway, or to use manual techniques to remove the fluids before, during, and after artificial ventilation. Okay. Things to remember. Always use your PPE when managing that airway. Your airway assessment must be an ongoing process. Remember, just because we checked it at the very beginning doesn't mean that if we don't check it at the further down the road, then we may lose our airway, and then we're scrambling to try and figure out how we're going to fix it. Okay, so ongoing airway management, ongoing airway assessment in every single patient, because airways are probably the single most thing that can go downhill fast. Okay, should start simply and become more complicated only if necessary. Again, check that airway, make sure that you get that airway good. Don't just let that airway be checked once and then forget about it. Okay. So these are things that I want you to go over. So name the main structures of the airway. Explain why care for the airway is our first priority in emergency care. Describe the signs of an inadequate airway. Explain when to use the head tilt chin left maneuver, or the jaw thrust, and why. Explain why airway adjuncts and suctioning can help in airway management. Okay. I'm not going to go through these critical thinking. You'll have an assignment on critical thinking in your online classroom. So if you have any questions, let me know. You can email me, text me, call me, whatever, and we'll get them.